Welcome to the Defeating Epilepsy Foundation YouTube channel. In this presentation, we will discuss what the hypothalamus is, the functions of the hypothalamus, hypothalamic dysfunction, symptoms, evaluation, treatment and management. Make sure to like our videos and subscribe to our YouTube channel. Click on the bell to be notified of future videos. Please click on our donate link in the description section below and donate today. Your donation helps us to make a difference for those battling epilepsy. We appreciate your support. The hypothalamus is the brain structure that connects the central nervous system to the endocrine system. It acts as the body's central coordinating center, regulating metabolic functions by stimulating autonomic nervous system activity and hormone release. The hypothalamus primarily works to maintain homeostasis, a state of internal equilibrium. It achieves this through self-regulating physiological processes that stabilize body functions. The pituitary gland, which secretes and releases the hormones that regulate these bodily functions, is controlled by signals from the hypothalamus. By sending out these signals, the hypothalamus can manage mood, sex drive, sleep-wake cycle, appetite, breast milk production, blood pressure, body temperature, and growth. Through communications with the anterior and posterior pituitary, the hypothalamus is involved in the production and secretion of the following chemical messengers. Antidiuretic hormone, ADH, helps maintain blood pressure and water volume. Corticotropin-releasing hormone, CRH, which regulates metabolism and immune response. It is particularly responsive to stress. Gonadotropin-releasing hormone, GnRH, which influences the release of sex-related hormones. Oxytocin. This hormone aids in childbirth and breast milk production. Prolactin-controlling hormones, including dopamine and estrogen, are also involved in breast milk production. Thyrotropin-releasing hormone, TRH, which regulates thyroid gland activity. Damage to the hypothalamus can impair the functioning of several physiological processes, such as lactation and body temperature regulation. Hypothalamic dysfunction can be caused by traumatic brain injury, tumors, infections, brain defects, swelling, or surgery. Nutritional problems, radiation treatment, e.g., chemotherapy, genetic disorders, and inflammatory diseases may also lead to hypothalamus-related issues. Symptoms associated with hypothalamic dysfunction include the following: irregular blood pressure, low or high, infertility, poor bone health, water retention or dehydration, delayed puberty, poor muscle tone, body temperature fluctuations, insomnia, malnutrition. While hypothalamic dysfunction plays a significant role in several hereditary conditions, including Prader-Willi syndrome, diabetes insipidus, and Kallmann syndrome, it is also a prominent characteristic of functional hypothalamic amenorrhea, a condition marked by a prolonged absence of menstruation. Hypopituitarism, pituitary gland hormone deficiency, and a range of hypothalamic pituitary disorders. Hypothalamic damage can affect the lives of people with epilepsy via hamartomas. Hypothalamic hamartoma, HH, is a rare, congenital tumor-like growth that can lead to precocious puberty, gelastic epilepsy, developmental delays, and cognitive problems. While it may present itself as asymptomatic for several years, the condition becomes more apparent as people start exhibiting signs of central nervous system dysfunction, hormone imbalances, behavioral disturbances, and seizures. Hamartomas can cause disruptions in the bodily functions regulated by the hypothalamus as well. Gelastic seizures, which are characterized by sudden fits of laughter, are the most prevalent symptom of epileptic hypothalamic hamartoma. However, other types of seizures can occur: atonic seizures, which are marked by loss of muscle tone, diachronistic seizures, which are akin to bouts of crying fits, and tonic-clonic seizures. These cause uncontrollable muscle contractions and a loss of consciousness. Gelastic convulsions are quite challenging to control as they cannot be treated with anticonvulsant medication. Fortunately, research has revealed that surgically removing the mass from the hypothalamus generally resolves epilepsy symptoms, suggesting that these seizures were inherently linked to the hamartomas. However, a study investigating the resurgence of seizures following the ablation of a hypothalamic hamartoma suggested that while gelastic epilepsy may be of hamartoma origin, the other types of seizures that can occur in the presence of HH may originate from other brain regions as a result of propagation or increased seizure sensibility of brain networks over time. Research on the hypothalamus also provides insight that can guide epileptic treatment procedures. In a study focused on the effect of electrical brain stimulation on drug-resistant epilepsy, DRE, symptoms, Benedetti Isaac and colleagues found that deep brain stimulation, DBS, of the posteromedial hypothalamus had the potential to control aggressiveness associated with DRE and reduce the rate of epileptic seizures. Clinical symptoms shape the diagnostic toolkit for hypothalamic dysfunction. Blood and urine tests can help detect any hormonal abnormalities, if any, by determining patients' levels of serum cortisol, serum estrogen, pituitary hormones, growth hormones, testosterone, thyroid hormones, sodium levels, and blood and urine osmolality. Other diagnostic tests may include brain imaging scans such as MRI or CT, visual field exam, for tumor detection, hormone injections, genetic analysis, and autoimmune markers. The emergence of MRI as a diagnostic tool has proven to be particularly helpful in the detection of hamartomas of the hypothalamus. Electroencephalograms, EEG, can be used to monitor electrical activity in individuals with epileptic HH, but gelastic seizures may not be detected since this test does not record deep brain activity. There exist differential diagnoses for some of the symptoms observed in people with hypothalamic dysfunction. For instance, sleep problems could be caused by substance use, sleep-altering stimulants, psychiatric conditions, e.g., GAD or MDD, and REM sleep behavior disorders. Other conditions that can imitate the signs of hypothalamic dysfunction include pituitary gland lesions, which mimic hormonal deficiencies, central or nephrogenic diabetes insipidus, which is caused by antidiuretic hormone-related issues, and hyperthyroidism, which causes an increase in appetite. Depending on the condition and severity of hypothalamic dysfunction, treatment options may include a variety of medications. Pharmacological interventions for hypothalamus disruptions usually target hormone replacement and nutrition, i.e., for appetite regulation and weight gain. Hormone replacement therapy can vary in length. For Kallmann syndrome, this treatment is lifelong. For tumors, surgery or radiation therapy may be required. This is especially true regarding symptomatic hypothalamic hematomas with uncontrolled seizures. However, other options such as thermoablation and radiosurgery can be used instead. The hypothalamus is the bridge between the hormonal glands and the central nervous system. It coordinates essential bodily functions to maintain homeostasis. Evidence suggests that hypothalamic damage can cause hormonal imbalances, autonomic dysfunction, cognitive disturbances, and seizures. Research into the relationship between the hypothalamus and epilepsy could uncover underlying mechanisms contributing to the generation and propagation of seizure activity and pave new therapeutic avenues. To learn more about the hypothalamus, please check out the resources used in the presentation today. Please like and subscribe to our YouTube channel and follow us on our social media pages. We would love to hear from you. Leave a comment below or email us at info@defeatingepilepsy.org. Thank you for your support, and together we will defeat epilepsy. Check out our other great videos and subscribe today. You have the power to defeat epilepsy.